Okay, distinguished guests, Professor Giamarellos-Bourboulis, Professor Reinhart, Dr. Jashi, Honorable my friend Baptista Leite, of course, distinguished guests, colleagues, friends, it is my honor to welcome you all to the 8th annual meeting of the European Sepsis Alliance. As the European Sepsis Alliance patron and a long-standing friend of the Global Sepsis Alliance, I am delighted to host this meeting at the European Parliament. After the historic launch of the 2030 Global Agenda for Sepsis at the German Bundestag in 2024. Today, we come together with a shared commitment to addressing the challenge of sepsis, a threat that affects millions of lives across Europe and the globe. Sepsis remains the leading cause of preventable death and disability in Europe, claiming over 680,000 lives annually. Each year, more than 3 million people in the European region experience this medical emergency. Of those who survive, many face long-term, life-challenging and life-changing consequences, including disability and post-sepsis syndrome. Being cardiovascular doctor, being cardiosurgeon, and intervening those patients with sepsis, I know what does it mean. Really terrible situation. Yet despite this, its disadvantaging impact, sepsis remains largely overlooked in political discourse. And our collective response has been insufficient, colleagues. It is now up to us to do more, to raise awareness, and to unite our forces, because I see unite from my right side, and it is very important now to follow this slogan, unite. Since the 2017 World Health Assembly resolution, only 8 countries in the region have developed national action plans or policies to combat sepsis. And only 10% of hospitals have 24/7 access to blood culture incubation and pathogen identification for effective management of sepsis. Very low level, very low level. EU has no comprehensive policy or strategies planned for sepsis. The ECDC should develop guidance and tools for sepsis surveillance and capacity buildings. Sepsis is not yet integrated into the HERA work plans. Even though the estimated 35,000 IMR-related deaths in the region are part of sepsis-related deaths and similar to the COVID-19 pandemics. You know, 70–80% of COVID patients in intensive care units had viral sepsis, but sepsis. And future pandemic will increase sepsis risk, no doubt. Today we come together to reaffirm the urgent need for coordinated leadership and policy change. We must work with European leaders, including the European Commission, the European Parliament, and our member states, national parliaments, governments, of course, also our professional alliances, to ensure that sepsis is recognized as a serious public health threat it is. We must start work on the development of a European sepsis strategy, one that integrates sepsis into our healthcare systems, increases awareness of policymakers and public, and ensures adequate support to sepsis research. This meeting represents a valuable opportunity to build momentum towards these goals. With the support of dedicated organizations and individuals, including today's distinguished speakers and panelists, we can create a future where sepsis is no longer a hidden epidemic. Now, we can state very clearly, it's a hidden epidemic. It's up to us to change that direction. In this spirit, I welcome the call for action developed by the European Sepsis Alliance and endorsed by 16 other European and global health organizations. By working together, we can save lives and prevent human suffering caused by this devastating medical emergency. Working together, how is excellent, how sounds this word? When you see WHO level and we see some countries decided to leave WHO, can you imagine in which environment now we are all staying? And now up to us also to send message that working together means to strengthen our capacities at WHO level, at United Nations level, at European level, at national level. Otherwise, we have no chance to stop new pandemics and sepsis and IMR, and of course also we can fight against those populists, against those, misleading or fake news, against those, some actors who are proposing, conspiracy-based theories, ignoring evidence-based, ignoring medical science, and ignoring real threat, because sepsis creates real threats. Thank you, colleagues. The floor is yours.
Thank you. Thank you so much, Vytenis. We're very, very happy that we can be here today. It's a great honor that we can be in the European Parliament, so thank you for inviting us. You've been a great patron to us. We will continue. I will welcome everybody also from the European Sepsis Alliance point of view. My name is Ulrika Knudsen, and I work with the Sepsis Fund in Sweden, but I'm also part of the board of ESA. But now I'd like to leave the floor to Evangelos, our dear chair.
Well, thank you very much. I would like to thank the honourable member of the European Parliament, Andriukaitis, for hosting us on behalf of the European Sepsis Alliance. And I am honoured to give this keynote presentation in the Parliament, and I would like to acquaint you with some real data and very important data which has recently been published, because you know that over the years we are presenting our data why there is need for support coming from the governmental levels, both at the European level and the local level. But now it's the first time where these data are accepted by the scientific community. We have a recent publication at the Blue Journal, which for us who are active in the field is considered as the top journal and the top level of evidence proving why sepsis is an urgency. Not only in terms of how many are the victims of sepsis, but also an urgency on how healthcare policy and healthcare practitioners needs to improve ourselves in order to meet the needs of our patients. This is my conflict of interest disclosure for this keynote, and the majority of you who are today with us, you know that it's almost 10 years that a new classification tool was introduced for sepsis. And exactly by using this classification tool, 5 years ago in The Lancet, there was a measurable estimation taking into consideration what happened in 2017 of how many patients are victims of sepsis and how many of them not only suffer from sepsis, but they die from this. And it's something really impressive. We have almost 50 million people worldwide, and of them, 11 million people die, and this happens in 1 year. And if you look at the web, how many over all the years of the pandemic were the victims of COVID-19, you very easily recognize that in 1 year, sepsis killed many more patients than COVID-19 during the entire pandemic. And why it's so important and what's the key in order to decrease death? Over the years, there is a gold standard for us for sepsis management. That if you manage to recognize early and treat early, how early? The very first 1 hour. Then the likelihood that your patient survives is fair, but the more you delay, you see that for every hour of delay, the chances of survival decrease by a relative 7.6%. So the real question is, can we do that? What I just presented to you appears simplistic, but it requires two things. First of all, to recognize the patient, and second, to have a system of alertness in your hospital to treat immediately. Does that exist? That was the real backbone of what we call the European Sepsis Care Survey. In other terms, in all healthcare levels of healthcare, which could be even the general population, the emergency department, the general ward, the intensive care unit, what we have in terms of resources and what people know about sepsis. Regarding the emergency department, are there tools for early recognition? In the ward, are there protocols for recognition and treatment? In the intensive care unit and in the ward, do we have the proper diagnostic capacities? And also, do we have in place in our hospitals auditing systems to see if this works or not? So what we did is, through a web approach, there was a questionnaire which was developed by the steering committee of what we call the European Sepsis Care Survey. It was reviewed by the big societies of Europe, of UK, and that was distributed to national coordinators, and we asked healthcare professionals to give their feedback and to know, not only in Europe, but also in other countries, what is the level of quality actually in all these different levels for the management of sepsis. These are the participating countries. The vast majority is coming from Europe, but we had also participants from other regions of the globe. And let's go now to the most crucial step. Screening for recognition of sepsis. Is this sufficient in the emergency department, in the ward, and the intensive care? What you see for each of these levels of care, emergency ward, emergency department, general ward, intensive care unit, you see 4 bars. Each of the bars represents a different geographic distribution. As we move from left to right, it's Eastern Europe, it's Asia, Southern Europe, Western Europe, and Northern Europe. And the question is, how many of these levels of care they provide tools for sepsis, for early sepsis screening. What you have in the green line, which is actually on top of the graph, is what is considered from an auditing perspective the gold standard. And you see that this gold standard is not available in none of the countries and in none of the levels of healthcare. And if we change that, the readout of the slides is exactly the same. The hospitals providing sepsis management according to the current Surviving Sepsis Campaign guidelines, we come across exactly the same problem, a complete lack of provision of appropriate sepsis management. And the next question is, are there initiatives to improve the quality? In other terms, is anyone in these healthcare facilities, an administrator, interested to see if for sepsis is done what is needed to be done? But in order to learn if what needs to be done is done, you need an audit. And you see different graphs for Northern Europe, Asia, and other places, Eastern Europe, Southern Europe, Western Europe, as we move from left to right. The blue represents any kind of quality improvement program. The dark blue, quality improvement problem located only in that specific hospital. And in yellow, hospitals who are interested to invest on improved quality. And I mean, it's really very low. So the conclusions from what we know and what is published in the Blue Journal is that the majority of units, they do not have standardized screening. There is no SOP for management of sepsis. 70% of the hospitals have no training or quality improvement program. Almost 90% of the labs have limited service just for blood cultures. So there is a publication in intensive care medicine, which is endorsed, and it's a collaboration between the European Sepsis Alliance, the European Society of Intensive Care Medicine, the European Society of Clinical Microbiology and Infectious Diseases, providing suggestions that all these, which are considered essentials, structures, basic measures, improvement approach, audits, needs to be done. But I believe that the most important thing of what we're been doing, because what I'm presenting you so far is the point of view of the healthcare professionals, is what our patients are teaching us. And the way they're teaching us is the survivors from their own experience. And I would like to emphasize that this publication in The Lancet is a collaboration between members of the steering committee of the European Sepsis Alliance, but also of sepsis survivors. And they suggest that, first of all, at all levels of healthcare, there is need of education and training, that at a certain time point, when you are discharged from hospital, someone needs to give you a discharge with the name of sepsis and not of an infection which is hiding before that. Sepsis needs to be registered and documented accurately, and that clinical pathways for improvement needs to be there. And finally, national public health campaigns are needed. Educational packages on infection prevention, vaccination, hand hygiene needs to be endorsed. And national governments should ensure universal access to sepsis management and affordability. And also, European authorities and national government should invest in sepsis research, because if you don't invest in research, you cannot get the correct tools. So our patients are our heroes, but I strongly believe that all those who participated not only at the European Sepsis Care Survey, but also all healthcare professionals who provided their contribution to it, they did something really heroic, because what I presented to you is not only something that we have found, it's something which is now universally accepted by the scientific community and published in one of the top journals. Thank you very much, and I welcome you to our annual meeting.
Thank you so much, Evangelos. Yes, so we are now going forward with some other high-level remarks, and I would like to give the word to Professor Konrad Reinhart, who is the founding president of Global Sepsis Alliance and also president of the German Sepsis Stiftung. So welcome, Konrad.
Thank you so much, and before I start, I really want to address and applaud you. We have met, I think, in 2015 in the British Embassy in Berlin on the occasion of an AMR meeting. And I addressed you and asked you that we are about to organize and establish a European Sepsis Alliance. And I felt so comfortable that you said, I know what sepsis is. I am a surgeon and I have lost so many patients. And this, after 3 weeks, we had an appointment here in Brussels, and this was the start of a journey. And if any high-level policymaker would act like you, so we could annually save millions of lives. This is what it's all about. And if I have made my first slide, in 1899, Sir William Osler has said, mankind has 3 major enemies. One is famine, one is hunger, one is war, and one is fever. And by far, the greatest is fever. And what he has said at this time is still true today. Look at these figures, because recent data from 2019 confirmed that we have 13 million deaths. And if you look on this paper, just 7 million deaths are associated with bacterial infections. And what these authors of the Burden Disease Report say, according to their criteria, only those deaths would rank the second leading cause of death globally. And we are talking about 40% more cases of viral sepsis. And it's not only an issue in low-income settings. Look at the incidence in countries where we have looked into healthcare records, where we have found that the incidence is that high, and it's still not an issue of high-level policymakers. And you have rightly mentioned, and we have set this already out in 2017 in the report for the WHO sepsis resolution, where it was already mentioned there that also viruses may result, and we have experienced it, and I don't need to explain it again. And this is the most recent report by the Agency of Health Research and Quality Improvement from the US. And what they found in 2025, they had 2 million deaths, and not deaths, but cases of non-COVID sepsis, but 500,000 of COVID-related sepsis. And how come that everybody knows about COVID? Because policymakers have addressed it, have spoken about it, not mentioning that this is viral sepsis, as you rightly addressed, and we need to get there, that because otherwise we must, as you rightly have said, also address the hidden pandemic, which is several times higher as those. And if you look into detail what this means from the patients, and luckily still the US have data. They know that sepsis is the #1 cost driver in the US hospitals. It's also the main cause of death in the hospital. 35% of deaths in the US in the hospitals are related to sepsis. They know that 60% and up to 70% of patients suffer from long-term sequelae. This is such a burden to our health economic situation and for our economies, because we are all in an aging population, have major issues there. It's the second leading cause of maternal deaths. It's more children die from sepsis than from cancer. And it's also, of course, minorities and disadvantaged groups suffer most. How come that this is not an issue and was not an issue when we came up? And hopefully, and this was a reaction by Chuck Schumer, jointly with the Staunton family, in the last month of the presidency of Biden, they held, on the occasion of this quality report, a first meeting in the White House. And this is where sepsis needs to be, in the high level. And why was it? Because this child of the Stauntons was known by Chuck Schumer. But it cannot be that our policymakers get only active when they have somebody in the family. So, yeah. And as we heard, most deaths of sepsis are preventable by vaccination, clean care, early recognition, and management as an emergency. And what you see here, there was a dramatic, and this is data from the US in 1900, the crude mortality rate, or the number of infection-related deaths / sepsis were 800. It dramatically declined due to healthcare measures, including chlorination, sanitation, setting up of health departments, etc., vaccinations and antimicrobials. It was only interrupted by the so-called Spanish flu. And unfortunately, this success, which happened only in one country at this time, in the highly enveloped country, has made us forgotten about sepsis. But also in high-income countries, sepsis can be reduced dramatically. This is the decline of ICU-treated sepsis patients in Australia between 2000 and 2012, just by measures, quality ensuring measures, meaning education of nurses, doctors, in the early recognition in the wards, and having what is called rapid response team that they can address. So, and mortality went down from 35% to around 18%. And what they then have achieved in the aftermath was a decrease even more by addressing and looking and starting quality improvement initiatives. And the last one, which was published in the most common hospitals in the state of Victoria, just by a campaign which was named "Be Aware of Sepsis and Act Fast," resulted in a further decline of mortality from 70.5% to 11%, which meant a decrease in hospital bed use, a reduction in mortality, as you have seen, but also saving of costs by 600% return of investment. So that it brings money, it saves money, it keeps us valid. Rory Staunton regulation, where you see was implemented, and within 2 or 3 years it was published in the New England Journal, and not only for adults but also for children, where you see that those who have followed these bundle suggestions, the first actions that you need to do in terms of rapid fast, resulted in a almost halving to 7% hospital mortality in the age group of 0 to 17 years. When I looked up what we have in Germany, we have 16.2%. How come? Yeah, we have the resources, but we have not awareness, etc., etc. So, and that's the slide with which we started. And the death numbers here are calculated based on the death rate in Sweden, which is half as high as in Germany. And if we would have in Europe the same mortality as in Germany, the numbers of deaths and preventable would be even higher. And this is data to our esteemed member also of the big group of Adam Lindner from Sweden, who have done a great job during 19. You see, hospital incidence, sepsis, including sepsis due to COVID-19, together was 6.7%, meaning that 6.7% of all hospitals in Sweden during the pandemic were sepsis cases. The population level of incidence of non-COVID sepsis was 815 per 100,000 population. The 30-day case fatality rate was 15.5%. And they looked also up on the importance of AMR. Yes, it's there, but it was only because of their high-quality healthcare system, 7 per 100,000 population, meaning 2.3% of all sepsis deaths were related there. And if in these patients, the case mortality rate was 24%, even higher as the average mortality rate, I would guess, in the rest of Europe. So these are the gold standards. And you have seen the big difference in the slides by Dr. Giamarellos. They have been doing something. It's not, it's real because they act accordingly. So, and we have to choose our priority. This is
Konrad?
again CDC data.
Konrad, can
Yes.
I just be mindful of the time because we're running a little bit late.
So I am there. And just to let you know, you have mentioned the AMR number for Europe. We don't find almost not mentioning the word sepsis in the according initiatives against AMR, which in Germany, out of 18 suggestions, only one was related to sepsis. And we have to follow the recommendations to synergize, and sepsis can affect everyone. And this is the knowledge on sepsis, and with this I stop. Most of the people still think 60% sepsis comes from wound infections. They don't know that also influenza and COVID-19 may follow up. This has impact on the low vaccination rates that we face in these countries. And what we need urgently is to combine what you have rightly said, all these issues, sepsis, AMR, pandemic preparedness, in strategic, holistic approaches. Thank you so much. And we have to learn.
Thank you so much, Konrad. Thank you. We will now hear from Dr. Ricardo Baptista Leite, who is president of Unite, which is a parliamentarians' network for global health. Please.
Thank you very much, and good afternoon, everyone. The sepsis movement is truly fortunate to have such passionate leadership, and I think we can all share that and feel that in this room. Of course, Konrad, my dear friend, thank you so much for your leadership and for the invitation. Also to Evangelos and to Mariam Jashi, of course, as CEO of the Alliance. I'm here as founder and president of the Unite Parliamentarians Network for Global Health, of which Mariam, as a former parliamentarian, is also part of. We are a network of current and former legislators from 116 countries around the world promoting science-based policymaking. And we are deeply honored to be here in the presence of my dear friend, Honorable Vytenis Andriukaitis, today as a member of the European Parliament, but with whom we've been side by side also in his days as Commissioner for Health of Europe. And I remember very clearly once I invited you to Portugal, my home country, to speak at a conference, and we were going into the conference room, and we were still outside, and somebody was smoking. And you tackled that woman, I remember, saying, I'm the European Commissioner for Health, stop smoking. And I swear to God, I think she still stopped smoking until today because she's afraid you'll be back. So you're doing an amazing job forever as a defender, as a global health champion. And we're so honored to have you also in the Unite Network. Thank you for your amazing work and for being here in the Parliament in a time when we need voices like yours to speak up. These are the times when being silent is playing against humanity. And so, thank you. When we're looking at all of the things we're discussing and thinking about sepsis within the context of the Sustainable Development Goals, we can't stop but yet be concerned about how slow we've been progressing. The Secretary General of the United Nations acknowledged that we've only accomplished around 17% of the SDGs. 10 years have passed. We only have 5 more years to accomplish the rest of the goals, which means we're not going to accomplish them, which means we have to rethink our strategy because what we've done until now is not working. And we know all the arguments. We know that health is a prerequisite for development. We know that investing in health is a precondition for economic growth. However, what happens in governments around the world is that the ministers of health are always seen as the burden of the cabinet. They're always put in a corner with very little political support. They're always seen as a cost and not as an investment. And this is a problem. Until our political leaderships, the heads of states, the prime ministers and presidents of the countries in the European Union do not understand that health has to be prioritized, we will not be able to solve these overarching problems. That society will then just continuously see a vicious cycle where we'll have more sick people, which leads to more vulnerability, which leads to more poverty in that vicious cycle that needs to be broken. And that is because we have a system that is driven by disease. We react when people get sick. We do not prevent disease. We do not focus on lowering the burden of disease. And we are now facing even additional challenges to these that we already had before. And we know that, as was mentioned by Honorable Andriukaitis, with the stepping away of the United States from the global health arena, leaving millions to die. What's happening in low and middle income countries in Africa, in Southeast Asia, in Latin America, is a shame and should shame us all as humanity because we are seeing it happen in real time. I personally thought when I saw things happening in history that we would not see them again in my time because of social media, because we knew about it. But we're seeing these things happening and we are unable to react in real time. Europe needs to step up. Europe is the last beacon of hope when it comes to human rights. And so we have a moral obligation to step up, to put the resources where our values are. But the truth is we criticize those that have nationalistic views. But when it comes to health, we too should look at our mirror. Because when we talk about a European Health Union and so forth, the member state governments are the ones saying, don't touch my health, that's a sovereign issue. If we want to address health seriously within the European context, if we want to maximize the resources that are available within our union, we need to work together, which means, yes, giving up a little bit of power at the national level, but thinking of us not as just national citizens, but as European citizens. And I believe this is critical now more than ever to be able to achieve our goals. And so Europe, and when I say Europe, it's Europe beyond the Union. We need to work with the UK. We need to work with Ukraine. We need to work with neighboring countries that want to be part of our family. We need to develop the actions of repositioning health as a priority. And that leads us, of course, to sepsis. We heard the staggering numbers that Konrad presented to us here today. And we saw how Evangelos showed us how even the most advanced countries in the European Union are far behind the gold standard of what should be accepted or should be acceptable. 1 in 5 deaths worldwide are caused by AMR. And we know the direct link with sepsis. We had a high-level meeting on AMR in New York last year. As most high-level meetings, there's a feeling that we got together in New York and nothing happened after that. We need to do more than that. And we need to be consequential on the declaration that was made, and we need to be consequential on this, which is the 2030 Global Agenda for Sepsis presented by the Alliance. We know that sepsis is opportunistic, which means it will affect typically those that are in most vulnerable situations. It's not by chance that the map of distribution of sepsis deaths and victims is what we are seeing. And ultimately, it is for people who survived sepsis, who died with sepsis, the people citizens that we can prevent being infected, that we are here today. And the truth is, many of the actions that have been proposed in this global agenda are far from being implemented. And so the Unite Parliamentarians Network for Global Health has committed itself to collaborate ever more with the Global Sepsis Alliance, precisely so that we can address many of the challenges, not just in terms of raising awareness, but actually towards the implementation of the recommendations, mobilizing the parliamentarians in each country, but also here in the European Parliament, towards these causes. And there has been a call for a European sepsis plan. And being here in the European Parliament, I think we should call for that also here today. And this mandate, we should not let this mandate end without a European sepsis plan with clear actions, with clear resources, and clear metrics that we can measure in terms of results. Because, as Konrad was showing, there are examples within our union that are doing better than others. I just came from Stockholm, actually, this Monday, and it's staggering, the difference. You mentioned Germany, I could mention Portugal, still far behind. We can learn from the best, and together rise that tide so that everyone can benefit from the power of science. I know I'm at time, so I want to end just with a personal story that I told in my last meeting with the Global Sepsis Alliance. I'm a physician by training, trained in infectious diseases, and I volunteered as a medical doctor in the regional hospital of Lviv at the beginning of the Ukrainian war. And I was still a member of parliament at the time, and I used the summer recess to go to the regional hospital of Lviv. And although I was an ID doc, they put me in the neonatal care unit because that's where they needed most help, with newborn babies that were in very severe situations because of the war conditions. Of course, we know that following pregnancies became a major challenge, and well, all the people still get sick in wartime, right? People continue to have heart attacks, people continue to have diabetes, people continue to have sepsis. And when I was in that ICU for newborn babies, I met a 7-month born baby called Milana, who was struggling for her life. Nobody thought she would survive on a multiple course of antibiotics, trying to save her. And at the end of my time in Ukraine, I was already seeing that baby outside of the incubator on her mother's breast. And 3 years later, I can tell you that baby is 3 years old. She's as old as the war, a war that should have ended by now. And I will always know her age because of that. But she was a survivor. Not all babies are that lucky. Not all adults are that lucky. We need to do more. And if we didn't have the science, we could just cross our arms, but we know what can be done to save lives. It is our obligation, be it in civil society, to politicians, to the scientific community, to come together to make sure that the recommendations that are so clear become a reality. As we like to say at our organization, it's time to unite. Thank you very much.
Thank you. Thank you so much, Ricardo. Very glad to have Unite on board with us too. Thank you so much. Now we're going to talk a little bit about the 2030 Global Sepsis Agenda for Sepsis that Ricardo was talking about. And our CEO, Dr. Mariam Jashi from Global Sepsis Alliance, will talk a little bit more about this.
Thank you. Esteemed colleagues, dear participants, Ricardo, thank you so much for being such a great supporter of the Global Sepsis Alliance and the European Sepsis Alliance. And of course, we have to thank Honorable Andriukaitis for being the patron of the European Sepsis Alliance. In my current presentation, I will briefly review the 2030 Global Agenda for Sepsis. That is the very first multi-year global strategy that we launched at the German Parliament in September last year. And we were honored with the special video addresses on the 2030 Global Agenda for Sepsis from Dr. Tedros, the WHO Director General, as well as the Regional Director for WHO, Dr. Hans Kluge. And we're again grateful for the Unite Parliamentarians Network, Virchow Foundation, and the Global Health Subcommittee of the German Bundestag for this opportunity. The document, of course, highlights the immense human, social, and societal and economic burden of sepsis, affecting almost 50 million people every year, and based on the latest estimates, taking over 13 million lives. And if we look at the European map, 3.4 million people affected every year, and sepsis annually takes 680,000 deaths. Unfortunately, despite those numbers, sepsis is still invisible. For example, United Nations and EU rightly prioritize AMR, but sepsis is still invisible, while the 4.95 million associated deaths to AMR are only part of the 13 million sepsis-related deaths. The same is true to the European context. The EU prioritized AMR due to the 35,000 AMR-related deaths. However, against an extremely important AMR challenge, it affects older adults over 65 years of age with 13 times higher hospitalization risks due to sepsis. 78% of the COVID-19 patients in ICUs had viral sepsis, and every future pandemic, irrespective of the pathogen triggering the pandemic, will lead to increased sepsis risks. 120 armed conflicts, and we spoke just about Ukraine. We have Middle East crisis, humanitarian crisis affecting more than 360 million children and women. They are all subject to increased sepsis risks. And finally, climate change also exacerbates the risk of infectious outbreaks and sepsis. It's also important to remember the economic value, economic cost of sepsis. Every patient per median medical expenditures for septic patients is 36,000 euro, and this is only 20 to 30% of the overall associated costs. Sepsis costs 2.65% of national health budgets, and after 1 year of hospitalization, almost half, 50% of people remain unemployed because of productivity loss and disability and post-sepsis syndrome. Yet we have excellent examples from Australia, Canada, and US that sepsis can be prevented. We can save lives and save costs. Globally, we have only 15 countries with national action plans, and only 6 countries, only 1 in 5 EU countries, member states, have prioritized sepsis, either having national action plans or national programs. And in terms of the priorities as a call to action, at the EU level, we have to develop regional sepsis plan for Europe through partnership with European Parliament and the EU Commission. We need to establish European Parliamentary Group on Sepsis and initiate EU sepsis resolution. We have to call ECDC for guidance and standards. We have to collaborate with HERA for integrating sepsis in AMR pandemics, armed conflicts, or other threats. We need sepsis-specific research from Horizon, Erasmus, and other EU programs, and we need investments in novelties, new vaccines, prevention commodities, diagnostics, treatment, and post-sepsis care and rehabilitation tools. And at the national level, we have to call governments to establish national action plans for sepsis and integrate it into universal health coverage, AMR immunization, healthy aging, and other priorities. We need to integrate sepsis in pandemic preparedness, emergency and climate mitigation plans. We need governments and creating official development assistance for sepsis. And finally, we have to ask EU member states to join high-level political panel that we are planning to establish later this year that will advocate for mainstreaming sepsis in G7, G20, UN General Assembly, World Health Assembly, and other high-level forums. So thank you for your attention, and looking forward to the panel discussions.
Thank you so much, Mariam. We're really looking forward to how this can really be implemented in Europe, the global sepsis agenda. Now we are going to have a little panel discussion and on the topic prioritizing sepsis in Europe's public health agenda, and we will look upon it in different angles. And with us today to moderate this panel is Dr. Ron Daniels from UK Sepsis Trust and a physician in England and also part of the Global Sepsis Alliance board. And I will leave the presentation of the other participants to you, Ron. So.
Thank you so much, Ulrika, and thank you to esteemed colleagues, supporters, ambassadors, patron who have opened this meeting so brilliantly. So as you've heard, I'm Ron from the UK. I'm on the steering committee of the ESA, as well as one of the vice presidents of the Global Sepsis Alliance. We have a number of people within this panel. In the interest of time, because we are slightly late, I will introduce people with their permission. I'll take that liberty. So opposite me, from left to right, we have Dr. Nora Luti, who was over there, who is within your programme as working at the University Children's Hospital in Zurich. She's actually an adult intensivist, an intensivist who looks after adults. She's also charged with conducting the Swiss sepsis programme, responsible for delivery of the Swiss National Action Plan. We then have Shahzad Kiavash, who is a sepsis survivor and triathlete on your programme. But inspiration is a very overused term, but what you won't know yet is that she is also a displaced human, having been displaced from Iran to Sweden. She suffered sepsis in 2012 and lost limbs as a consequence. Just 3 years later, undertook her first triathlon, and 1 year after that was representing Sweden at the Paralympics in Rio. We then have Marian Haverkamp, also inspirational businesswoman, mother, and thought she was unbreakable until she developed sepsis in July 2021, and we'll hear from her. Moving to my side of the table, we have Maurizio Ciccone, who works at Humanitas University and is one of the past presidents of the European Society of Intensive Care Medicine. He's practiced all over the place in Italy and Spain and UK and the USA, and was mentioned by JAMA as one of the most influential doctors of the pandemic. We have Professor Antonio Artigas, who works at the Autonomous University of Barcelona, founding member of the European Society of Intensive Care Medicine, and was honoured by them in 2023. And then we have Professor Jan de Wael, who's president now of the European Society of Intensive Care Medicine and works right here in Belgium, in fact in Ghent. And then, not forgetting our online participants, we have Marco Cavalieri, who is the head of public health threats at the European Medicines Agency, which is an agency that works to protect the health of humans and animals through the evaluation and approval of medicines, as well as Raquel Rodriguez Alonso as a policy officer at the Health Emergency Preparedness and Response Authority of the European Commission. So with those 9 participants introduced, I'd like to start with the importance of hearing the patient voice, hearing the perspective of those with lived experience and how that contributes to improving outcomes and improving policy action. And I'd like to start, if I may, with you, Shahzad. Could you tell us perhaps a little more about your story, about how important it is to you to hear about how patients have to be involved in awareness, education and policy change?
Thank you very much, Ron. And hi, everyone. I feel so honored to be here. I'm just going to move to the microphone. So, yes, I am a sepsis survivor. And, I lost both of my legs. But I strongly believe that that didn't need to be the case, because I felt that something was very off. I had a rapid heart rate. I was breathing really fast, and it felt like I was dying. So I called the emergency number in Sweden, which is 112, and the ambulance came. But even though I told them numerous times that there is something very wrong with me and it feels like I'm dying, they told me that I was having a panic attack. And, they left me. They told me that I could come to the psych ward if I want to. But since I felt that that wasn't the case, I told them that I could manage this myself. A few hours later, I collapsed in my kitchen, and fortunately, my brother was there to find me. And then it was pretty late. So they rushed me to the emergency room, and by some miracle, I am here today. Sometimes when I really think about it, I can't believe it, but that shouldn't be the case, and that says how important critical care is and how important it is to get the help that you need. But with that said, when I came out of it and I started speaking about sepsis and speaking about the things that had happened to me, I realized that people knew nothing about this. I mean, many of them called it blood poisoning. When I was in the newspapers in Sweden, I said, it's sepsis. And they said, no, it's killer bacteria, or it's a blood poisoning. And I realized how little people know about it, even the healthcare professionals, unfortunately. And then I made it my life's call to try to change this and try to educate people around this. And with the platform I had, right there and then when I was in magazines and on TV, I really tried to use that. And then I joined forces with the Sepsisfonden in Sweden. And then we have been doing some, well, we have been doing some great stuff, right? But we are not even closely there. When I heard about the urgency and I understand the economic burden and I understood the suffering that it is as a human being and as a society and as our loved ones who see someone they truly care about go through something like this, I thought that everyone would understand. They would react and they would do something about it. But I mean, here we are 13 years later and we're still saying the same things and it's like no one is hearing us. So I think the patient perspective, I forgot what your question was. I'm rambling on, but I think that the patient perspective is really important because when Ricardo was telling the story about the little child on her mother's breast, alive, I think something happened in the room. All of us could see that child, and we were all happy about that. And giving it a face and giving it a voice, I think it is so important, and I hope that we can together with the healthcare professionals, together with the policymakers, try to end this. I think it's time.
Absolutely, and thank you. And as a clinician advocate, I learned long ago how vital it was that we bring patient stories in. And while we've been sitting in this room, a disc jockey, a DJ from our Radio 1, BBC Radio 1, which is our most listened to radio station among young people, right now is in hospital with sepsis. And she's already contacted me and she's going to help spread the word. And it's just so important. Now, I forgot to introduce Professor Jalali Anand. Apologies, Jalali, who's another good friend who... Jalali, you brokered the very first patient meeting that we had in partnership with the European Sepsis Alliance last year. And again, as a clinician advocate, you've come to this realization that this is critically important. You're also advisor to the French Health Ministry. Now, how important is it for you that we use the voice of the patient to influence policy change?
Well, with my biased opinion, I think that we were failing solving the issue of sepsis for so many decades because we didn't listen to patients and their family. And so I think the most important thing to win that battle against sepsis is to know better that enemy, and the right way to increase the knowledge about that enemy is to listen to those were exposed to it. And I think by increasingly listening to you, to the patient's family, we will be more likely to be successful in again, preventing sepsis, in diagnosing sepsis much earlier than now. And also, we will be very likely to have people investing, the pharmaceutical people investing in R&D to find new drugs, but also the health authorities helping disseminating and facilitating the translation of these new molecules that are coming or diagnostic tests into the routine practice to profit and to benefit to the patients.
Thank you. And then coming to you, Marianne, if I may, obviously you've also been through this, and as I very briefly described, you also had your very exciting life turned upside down. And how has your experience been for those around you? What's been the impact on those close to you?
Well, what I still notice, my family is still, we had that conversation yesterday as well. They are still getting in panic every little thing that I have. So just a little bit of fever, just a little infection. My daughter, who was 5 years old back then and saw everything, she gets in complete panic. And my husband, well, he wants to run to the hospital every time I have something small. So it's almost 4 years ago now, and I think it will, I hope it's getting better, but I think it will leave its fingerprint forever. I think it affects a lot the family as well. Maybe they are even more suffering than us because we're in the hospital and we don't notice that much at the moment. But for them, I think it's very heavy.
Yeah, thank you. I think it's a point that's really important to make because we talk about these economic modelling, we talk about the fiscal studies, but it doesn't consider the sacrifices that people other than the patient have had to make. And partners being unable to return to work full time because they have to help with childcare and that sort of thing. And we often forget that. So thank you. We do need to move on. And thank you for that brief discussion around the patient's story. But I think we need to touch on the role of health professionals in this. Clearly they have a role, but how are health professionals able to drive improvements in sepsis awareness and care? And to talk to this, firstly, I'd like to ask Maurizio, please, to offer your thoughts.
Thank you, Ron, and thank you to the honourable members of the Parliament and everyone here in the Global Sepsis Alliance, European Sepsis Alliance, to invite us. I'm representing the European Society of Intensive Care Medicine, and thank you so much to your testimony of survivors, because this is the reason why we do this job, to be able to see people going back to life, and we want to do better because we want actually to help patients and families to have a better care. So really, thank you first of all for this. I think as a scientific society, we believe that we have support clinicians exactly on this mission, to provide better care for patients and families. And in practice, it means supporting clinicians on the 3 pillars of medicine that are clinical excellence, education, and research. And this is what we try to do. So research is very, very important. We heard from Evangelos and others. Without data, we cannot get things better. I think research is far too limited at the moment. It's focused too much into what happened at hospital level. So much happened before, and now we can go to that time zero earlier, but also so much as what you were saying is understanding what is the follow-up, what do our patients and their families need after they leave the hospital, and now we can support them to get better and really to be part and an active part of our society. So that's very, very key. Education for our healthcare workers and for people that maybe they don't work regularly or they don't work in intensive care. For us, it's very easy to spot sepsis, but we are all faced with diseases that we don't treat normally and usually and maybe all the time. And I think to help other clinicians to have a basic understanding of what is critical illness and in particular sepsis is crucial. And in this sense, I think it's very important that intensive care and intensivists, we go out of the walls of intensive care. One of our mottos, Ian Deval is our current president at ESIC, is that together we are intensive care. And I do believe that this has been together. Intensive care is not just what happened within the intensive care, but it's about the early recognition of critical illness and sepsis and really try to improve the quality of what we do. So I think a lot has to do with basic education, not just advanced education. For instance, very recently we started a program which is called Intensive Care Fundamentals. And the idea is really to give basic training for intensive care to whoever is a doctor that may be working in an intensive care unit, but why not somebody that maybe will have to recognize a sick patient in the ward. Maybe that's the most important part in what we do. And to support clinical excellence, clinical practice at the bedside. And not everyone is a researcher, not everyone is an academic, not everyone is lucky to travel the world and to come to meetings like this. Most of our colleagues, they need basic recommendations to provide high quality of care timely. And so I think that also initiatives like this one, but also like the Surviving Sepsis campaign that you know very well, a joint program between the European Society of Intensive Care Medicine and the Society of Critical Care Medicine in America, with endorsements from many societies, and you're also part of the importance of this. I think this is very key. So key recommendations that are actionable and that can really make a difference for such a time-dependent pathology. Thank you.
Thank you so much. And if I can come to you, Jan, as the current president of the European Society, and we've heard your challenges and your calls to action from Maurizio. So what practical steps can we take to ensure that professional societies collaborate together, work together, engage the multi-professional audience in doing what's right?
Thank you very much, Ron. I think indeed, fora like this are an excellent moment to come together and to exchange ideas. As Maurizio mentioned, this is one of our key focuses, and we are gradually going beyond the walls of intensive care, educating people in the hospital, but I think also we do have a responsibility in increasing the awareness, not only in the hospital, but also outside of the hospital. This chain of survival, I think, is very important. It's all about, I mean, if you're good at delivering the best intensive care, but you're unable to recognize the disease early, then this excellent care in the intensive care unit is of little value. So as a scientific society, but also as a group of professionals, including intensivists, including nurses who work in the ICU, who have dedicated to training, I think we remain committed to improving the awareness of sepsis and improving the care for the patients in the hospital, but also beyond. And this is another aspect that we now increasingly recognize and absolutely want to focus on. What happens in the ICU, in the hospital, also affects patients later on and the quality of life. And this is something we much more focus on now, and we intend to do so in the future as well.
Thank you so much, and that's very encouraging, and we anticipate and hope that our colleagues in emergency medicine, internal medicine and other disciplines will join us on this journey. I'd like to come now to the first of our colleagues who are online, assuming the technology is ready. And I'll just give Marvin a chance to catch up. But I'd like to come first, if I may, to Raquel, who's the policy officer at HERA, the Health Emergency Preparedness and Response Authority for the European Commission. If you could talk to us about sort of, I suppose, the learnings from the pandemic and how we can work together to identify risk as we move into the coming years.
Today and speak and share information on HERA's role.
Raquel, if you may, just one moment, we are not hearing you. We might need to come back.
Of course.
I'm sorry, Raquel, we will come back to you momentarily. So the next theme, and Raquel and Marco can contribute after the next theme, is the importance of quality improvement measures, key successes we can identify and challenges. And to sort of introduce this topic, I'd like to hear from Antonio Artigas, who's been doing a lot of work in comparing between countries, between hospitals, about quality improvement and the efficacy of it.
Do you want to start? I start, or do you want to follow? I can start.
Go,
okay.
We'll come back to Raquel in a moment.
So first of all, I'm very happy to be here and honored. This is my first time to be in the European Parliament, so thank you very much. As Pau Casals says in the unit in his nomination of the in the union countries, he say, "I'm Catalan." And Catalonia was the first country with the first parliament in the world. Now, Catalonia is a country with more than 8 million of people. And you know, I would like to give you a view, an optimistic point of view of how we can improve the care of patients with sepsis. And we were able to convince the health department, the health department of my country, and in 2015, and we implement this in 2017, we designed a territorial model for sepsis management in my country. When we should consider to create an inter-hospital emergency code in a country, and when the syndrome is prevalent, when the treatment impact in the morbid mortality, when some patients can require special human or technological resources, and the delay of access to the ICU impact on mortality. So that we did, the first thing is to reorganize the care of these patients in the different regions of my country. So we identify different levels of care, and where the patient should be transferred to have a higher level of care if it's necessary. And so we define these three levels with very well identify the responsibility to treat these patients. Yeah, no. Go back. Now. So, as it was discussed here, it's necessary to teach the caregivers, and so we decide to establish a training program with a learning utility, and to have a quality accreditation on sepsis in the different hospitals. And also to define a system to capture quickly these patients, as it was mentioned by the patients, and developing that we call the radar sepsis system, and that we were able to detect very quickly in the hospital or outside the hospital to identify these patients, and then to transfer these patients immediately to the appropriate place to be treated. And finally, to really to be from the practical point of view, we develop a training program using the mobile system, the mobile phones, to have a continuous accreditation of all the caregivers in the hospitals. So after this experience, after some years, and taking the opportunity of the survey in Europe, we were able to compare the results of the management of sepsis to other countries from the European Union, and also to the rest of Spain. And you can see Catalonia is in blue, is in the middle, is the column of the middle, and the performance, for example, for sepsis screening was much better after implementation of this national program compared with the other countries. And when you look on the quality improvement initiative in the different hospitals, also was much more implemented compared with the other countries. and also the quality indicators that are I think are very important to define a predictive model and to determine where there are areas where should be improved in the next future. So in conclusion, is a protocol for sepsis detection should be developed by all health care workers, from domiciliary and primary care to high technology hospitals. The septic patients who don't respond to initial treatment should be evaluated and placed on an ICU, independently if the hospital is a low complexity or a tertiary hospital. The quality improvement programs, I think, are very important, especially if you consider the time to administer the antibiotic or the time to normalize the arterial blood pressure. And feedback is essential to reevaluate and improve this strategy. And this should be done with a multidisciplinary point of view, participating physicians from different medical specialties. So thank you very much. I hope that this is a view, an optimistic view, that we can improve. And it's just only to try to implement new things, or as you mentioned, we should do better in the future. Thank you.
Thank you so much, Antonio. And for those who are interested and inspired by Antonio's important work and that of his team, there are examples all over the medical literature of quality improvement projects, some of them in Europe, some of them outside Europe, of course. And within Europe, I hope to reinforce this evidence and knowledge. We've been working with the European Society of Emergency Medicine around variation in sepsis recognition in the EDs in Europe. So that will be interesting when we publish. So we're going to try to come back with apologies again to you, Raquel, to talk about the work of the Health Emergency Preparedness and Response Authority and how that links to the problems of sepsis and antimicrobial resistance.
Hello, good afternoon. Can you hear me now? I hope. Is it working?
We are just working with our mixer desk.
Hear me right. I know it can be challenging at the Parliament.
It's a setting somewhere. The stream can hear her, but we in the room cannot hear her. Okay. It doesn't help anyway. Yeah, so Raquel, at the moment, the live stream can hear you and your wisdom, but we cannot hear you in the room. We will try once more, again with apologies, Marco and Raquel, once more to resolve the issue. And thank you for your patience. So another theme that we'd like to explore is the role of governments and NGOs and other related authorities and agencies. And as with her introduction, someone who is very heavily involved in this space is Dr. Nora Luti, who's been tasked with the wise spending of, I think, 50 million Swiss francs over the next few years to try to improve outcomes from sepsis in Switzerland. So please, Nora, tell us about how exciting this big challenge is.
Yes, thank you very much, Ron. It's 10 million, not 50. 50 would be amazing, though. But still, yes, it's quite an amount of funding. Yes, and I'm quite honored to be here and also kind of proud to represent Switzerland here. And it would have been possible because a few years back, Switzerland had not issued any coordinated action on tackling sepsis. Not that this sepsis is not a problem in Switzerland. We have a quite high burden of sepsis cases and mortality in Switzerland, also economic cost, of course. But it was until 2022 that we lacked any kind of action plan. And during the workshop, we consulted policymakers, patients and family members, but also clinicians, of course, and academic researchers, and it was very clear that we have to prioritize sepsis awareness, education of the public and healthcare workers in Switzerland, that we should promote research as well, and post-sepsis support for survivors and family members, and then issue and develop standardized protocols for early detection and treatment, but also for follow-up. And during the workshop, we were fortunate to have a member of the newly formed Federal Quality Commission present. And they realized that improving sepsis care could also improve overall quality of care of patients. So they realized that recognizing the deteriorating patient or educating public about sepsis signs or signs of severe illness could actually not only improve care of the sepsis patients, but overall safety and quality in the hospital. So we drafted a 5-year quality improvement program, and they allocated 10 million Swiss francs to implement most of the recommendations we issued in the action plan. So they are funding as a national campaign, on a public campaign of sepsis awareness, and also an educational program, not only for healthcare workers that work in hospitals, but also for students and nurses and allied healthcare workers. Then the development of protocols and care standards in the hospitals, but also primary care and post-sepsis support. And which is something that was very relevant for us as well, that they are also funding data collection and building up of a national registry that we can actually evaluate also the cost effectiveness of the program, but then also to create robust data, because we are still lacking surveillance methods for sepsis in Switzerland. So we have, yes, so I think that has been very fortunate, but we have also profited a lot from the experience from Germany. We had tremendous support from Euron, from UK, but also from Australia, that helped us to set up the action plan, that shared all the learnings and best practices and knowledge with us. And I think that was a tremendous help to actually get the funding as well. Yeah.
Thank you, Noura. And you're being modest. I would like to also remind you and those in this room that within those planning meetings, we had the patient voice at the heart of those meetings as well. So this was patient-centered design from the outset. And we're all very much looking forward to seeing how things move. And within the UK, although sadly I'm not in the EU at the moment, but within the UK, we've had similar sepsis national action plans, and they can be very effective, but it's how we can sustain them beyond the initial investment. And I think we've taken some steps backwards in the UK, which we really need to reverse and push forward. But someone else who's been working with this, and sorry for coming to you twice, Jalali, and I don't think we'll get to everybody twice, but you know, you've worked with the French Health Ministry and the French National Action Plan. And how do you sustain it? Because you get the interest of one minister. How do we then move to the next minister and keep this investment going?
The key to keep the subsequent minister motivated, continuing the plan, is to provide success. You know, and so the idea was just let's move step by step. Let's have concrete results and then show these concrete results, and for sure they will continue. And indeed, we started now almost 5 years ago, and what we have achieved so far is we have in place a national surveillance of sepsis at the global national level, but also at individual, up to small cities, and this on an annual basis. So we can show and produce on an annual basis number of cases from neonates to elderly, from private to public hospitals, from small village to big cities. And this is important because we can provide the politicians, but also colleagues, patients, and family with numbers. And numbers speaks. That is important. The second success was we were able to gather more than 16 different medical specialties, including the GPs, to build with the health high authority, la Haute Autorité de Santé, national guidelines that were released last February from home to home. So these guidelines are really being built with all the stakeholders, not only those working in the hospital or in intensive care, but also the GPs and patients' organization. And with that national surveillance, with these guidelines, we now have offered not only to the Minister of Health, but also to the National Social Security, who is paying for that, tools to monitor and to be able to direct money to these actions because it's really working or not. And finally, we are just setting up together in between the Minister of Health and the Minister of Education a national program in school to promote the prevention of sepsis through hygiene, through all these things, and targeting the youngest one in the society to try to rise, to have sepsis prevention being in the DNA of all citizens.
Thank you, Jalali. And that last point's important, and it's something we also do in the UK with our school children. It's making this as tangible to school children as plastics in the ocean, isn't it? They will drive change, and they will be our future generations of decision makers. So critically important. Thank you. We're going to try one last time, Raquel, and if it doesn't work, we will come to Marco to see if we can hear him. And if that doesn't work, you will have to accept my personal apologies and those of the ESA for the technology, and I will say some kind words about your organisation and our future direction. So, Raquel, please, can we hear you?
Hello, good afternoon. You can hear me very well. Thank you very much for the invitation. And I'm glad that you can hear me now. I do listen to myself with a bit of reverb. I hope you listen well in the room. So thank you for the invitation to speak today and share the information on the role of HERA. So we focus on strengthening Europe preparedness and response to major health threats. And those health threats are viruses with pandemic potential, chemical, biological, radiological, and nuclear threats, and also AMR. So we are fully aware that sepsis remains a critical concern, but this condition has so far not been included as a specific entity in this list of HERA priority threats that should be addressed. However, all work right after the pandemic, during the pandemic, and our work on AMR also impacts the outcomes of sepsis. So today we heard a lot about the need for training, the need for awareness, and in our case at HERA, we focus on supporting medical countermeasures, so the development, access, and availability of medical countermeasures that help target the three health threats that I described before. So how are we helping sepsis? At the beginning, it was also mentioning that it's not very known that viral infections also lead to sepsis. In our case, we have supported the development and the access to the COVID-19 vaccines during the pandemic. We do procurement of RSV vaccines or influenza vaccines, and also other infections, even bacterial vaccines like the TB vaccines. So through our support to the availability of those vaccines, we hope that it helps reduce hospitalization and sepsis care. And we also look at supporting the development of medical countermeasures for tackling bacterial infections. And we were talking about the burden of sepsis in children and in neonates. And in this case, we are well aware of it. And we have partnered with the Global Antibiotic Research and Development Partnership, GARDP, to support clinical trials to find treatments for neonatal sepsis. And we are also developing medical countermeasures such as diagnostics for rapid detection and rapid identification of bacterial and viral infections. So in our case, we have all these tools, so we do not focus on awareness, we do not focus on training healthcare forces, but we do focus on making sure that all the medical countermeasures that can be available are there and to support them along the pipeline. Thank you.
Callan. Thank you also for your patience and that of you, Marco. It's much appreciated. So, Marco, could you conclude by how that might relate to our missions?
Yeah, no, with pleasure. I hope you can hear me. And indeed, I can only concur on the fact that sepsis is a dramatic medical condition with a heavy burden on public health and healthcare system, and we need to do better. And I think we at the EMA, we are very much committed to support efforts in advancing cross-cutting science. As said, the best thing to do is to try to prevent sepsis. So to find tools to have preventions, to understand with good diagnostics, maybe using artificial intelligence, the right biomarker and personalized medicine, to understand how we can prevent sepsis from occurring. And then once sepsis is occurring, to think about what kind of medicine we can advance, because unfortunately, as you know very well, the pipeline is quite empty. There is not a huge interest from industry, and therefore we need to push ahead for the sake of public health in thinking about new ways of tackling this important condition. And also, let me say quite importantly that sepsis at the root cause, there are often bacteria for which we don't have yet a vaccine available. So it's also very important that we also expand our action in thinking about having vaccines in order to prevent serious infection with some of these bacteria. And that's probably the best that we can do in having then a potential reduction in the incidence of sepsis in Europe and around the world. But we are extremely concerned about the lack of funds on R&D. Also, what is available in Europe is probably not enough, and we do not understand why sepsis has to be so neglected. So it's really a pleasure for me to be here and to advocate European institutions, European politicians, really to push on the agenda on health and considering sepsis as really a priority. Thank you.
Thank you so much, Marco, and thank you again for your patience. You mentioned diagnostics, and I think the critical thing is that the breadth of diagnostics and the pace of development of the science is outstripping our ability to integrate them into clinical systems. These diagnostics have to be much closer to the patient. They have to be processed rapidly. They have to be prioritized, just as they are in most countries for conditions like heart attack, because at the moment, delays in processing, delays in laboratory is costing lives. So thank you for bringing that up. I think we would be wrong to close this session without a final word coming from our patient voices. And again, sorry to pick on you, Shasiad and Marianne, but you've heard a lot. And I know that you've worked very closely with the ESA, so you might have heard some of this before. But in this grand setting and with these commitments and with the evidence that's been presented of improvement, do you have any final words to sort of say whether you have any hope for the future, that fewer families will have to go through what you've been through, what yours have been through, and fewer people have had to go through what you've been through individually?
That's a good question. Yeah. I have to repeat it so I don't forget it. So do I have any hope for the future? Yes, I do. Because I believe, and I can see that in this room, and I can see it in other rooms that I had the honor to be in, that there are so many good forces, so many doctors, healthcare professionals who want to do good. And as it was said here today, this is why you chose that profession, right? You wanted to help people. So I believe in the good, and I choose to believe in the good. But in order to also make something happen, I think that we should really join forces, not only those of us who are sitting here today and who are fully committed to doing something good with this bad situation that we are in. I think that policymakers, and I think that it needs to come from higher up. Unfortunately, that is the case. And I believe that if we join forces in the EU and we have a plan forward and everyone just sticks to their word, I think that we can make it happen. Because I truly don't believe that anyone, I don't know, deserves to go through what I and many other with me have gone through. And most of them, unfortunately, are not even able to say that they are hopeful because they are not here with us today, because they're not living anymore. And I think that that is something to think about.
Thank you so very much. Those are really humbling words to hear. And I'm humbled by the academic work of colleagues and people operating in spaces that I don't operate in. But I think there is hope, and I think we've heard a lot of hope. We just now need action. And again, other news while we've been sitting here, and again, it is UK news, for which I apologise, but that's my privilege to do that because I'm moderating. I've just learned that we're re-establishing an all-party parliamentary group on sepsis in the UK, and 1 in 4 parliamentarians in the UK has volunteered to join that group. 1 in 4, which means it will be the biggest all-party parliamentary group in the UK, the APPG, on sepsis. So I think there is hope. So I would now like to pass over to our Chief Executive, Mariam Jashi, for conclusions and next steps. Thank you very much to all the panellists. It's very gratefully received, your contributions.
Thank you, Ron, and thank you for all the amazing panelists. We wish we would have more time for discussions, but of course, having this 8th annual ESA meeting in the European Parliament, I think it says it all. That's the level where we have to position sepsis. And Ron, congratulations for your amazing work in the UK. And we look forward from learning from you how we can mobilize more the parliamentary networks around the world. I believe that the best conclusion of the meeting is the call for action that we all developed together and that is currently signed by 17 European and global health organizations. I thank Unite, Virchow Foundation, German Health Alliance, and all the members of our partnership. And I would like to take a moment of special thanks to Jan and Maurizio. With the major ongoing event in Brussels, the European Society of Intensive Care Medicine is with us, and we really appreciate the partnership and we look forward to even stronger collaboration. This call for action summarizes what needs to be done at the European Parliament level, at the European Commission level, by HERA, by European Medical Agency, and most importantly, the member states, the EU member states. And we hope that the 7 action points that outline exactly the policy, institutional, and community level changes that needs to be taking place in the EU can become a reality through our concerted advocacy, collaboration, investments and research and development, and taking the pan-sectoral, intersectoral action against sepsis. Once again, many thanks. And if you would allow me, I would like to give final words of closure to the European Sepsis Alliance representative, Dr. Antonio Artigas, on behalf of Evangelos. Over to you, Antonio, and we can close.
Thank you, Mariam. I think if I need to summarize quickly this meeting, I will say first, there is an urgent call to improve sepsis in Europe. I think we need to think about Europe first. And I think this should be done implementing the national plan in the different countries, and also with the support of the European Union, because we are in Europe. The second point, I think, is research in sepsis need to be improved, and the European Union can have or can play an important role here, especially investing or dedicating a research program in the Horizon program of research of the European Union to try to promote the research in sepsis in order to improve the care of our patients in early detection, new treatments, etc. And I have a dream, and my dream is to meet again next year here with better results of the management of sepsis care in Europe. Thank you very much.
Thank you so much. Thank you for joining us. And this film from this event will be on YouTube for quite some while, so you can all look at it again if you've missed some good points. And for you who are here in the room, thank you for joining us. And please do stay a little while afterwards. We're going to have like a photo op with everyone. So thank you so much, everybody. No? Outside, maybe. Yes, thank you. Okay, outside. Thank you for joining us. And we hope we'll see you all next year, too.